Go. Hi, my name is Barb and this is Rhonda. Welcome to The View.
Let's talk about eyes. So today we're going to talk about phone calls, triage, and that documentation that turns into a phone message where other people have to read and analyze what information you've gathered, and you are basically putting something permanent into somebody's chart, and decisions are being made from that. The gold standards for message, taking messages. There's several different features that I think that make that gold standard, and everybody has different ideas about what is right and what is wrong. But one of the most important things is having a good tone when you're talking to a patient.
You want to stay calm and be able to reassure the patient.
If the patient's irate, upset, it doesn't matter whether it's a refill or whether it's something that is urgent, needing to get back to them.
Yeah, they just need you to stay calm and work through and listen to what their question is.
So their biggest concern is what you need to get written down, and you need to do that, and I call that the Abbott's and Costellos. Who, what, where, which, why, when. Abbott and Costello, they used to be a comedy group in the end, and they did a bit with baseball, and you had to go all the way around the bases, and where's on this base, and what's on this, and it was a comedy bit. But your Abbott's and Costellos, that's what gets you everything you need, so that when somebody's reading your piece of paper or your electronic message, what you're trying to convey to anybody, you've got every base covered so that they can read that and they understand everything that's going on, where they shouldn't have to come to you and say, hey, what did you mean here?
Right. And it's so important, especially when you have to go back to the doctor and ask a question. You know what they're looking for. So it's super important to get, like Rhonda said, all those who, what, when, where, why, before you put that final tickle in there, because it's such important information to get the big picture.
When you're talking about eyes, you always want to know which eye. One, both. You always want to know when it started, how long it lasted, if it's worse any time of the day, so that timing key. And it's very much like when you're doing your HPI in the chart, where you're going down that list and saying, what makes it better or worse?
What have you tried?
What have you tried? What's helped?
Yeah.
What hasn't helped? And that's if you're dealing with the eyes. Now, even if you're dealing with medication, you need to have the patient tell you, and that documentation is important. You're going to review it with the patient, but you're going to have the patient tell you what they're taking, because it's very easy for you to say latanoprost and they could be on Lumigan, or they could say Tobradex if they've been on it in the past, and really they're meaning tobramycin, or vice versa, and that can be even more scary, because one is just an antibiotic and one is an antibiotic steroid that has some side effects that have to be monitored in a different manner. So there's lots of different features that you need to gather that information from the patient and get that to know whether or not you're doing the right job by having the patient tell you, let me review this with you. And so you go back through and say, so it's the right eye, it's been crusty, lower lid. Is it the lid? A lot of patients will say lid, and really they're talking about eye or vice versa.
Or vice versa,
and so it's very important when somebody says that they're having redness and irritation. Is it the eyeball? Is there pain with eye movement? Does it keep you awake at nighttime? That's a pain level thing.
Yeah.
Where if it keeps you awake, that's a whole new level, where if you can't get to sleep and you have an ache in your eye, that's something that you want to get in. But if you have a little bit of crusting on the lower lid every morning when it's like stuck shut, that's different. But you also want to know the patient. You want to assess, use your skills of assessment.
Your listening skills.
Yes. What does the patient have for a history? If somebody has a nasty eye, but they've had a history of corneal ulcers in the past or recurrent erosion, that's a different type of thing that you need to put down there for that person who's reading it after you. Whether it be the scribe for the doctor who's relaying it to them. Oh, by the way, they have a history of this.
Right.
They have a history of that. If you have somebody that has implants, you need to look at those implants real quick. Wow, was that a +7 diopter, that means that they used to have a long eye. If they're calling with flashers and floaters, that's a little bit more urgent.
Yeah, all of a sudden that light bulb goes on. Oh, they're myopic. They're more at risk for a possible retinal detachment.
So you have the patient. One of the number one things that I think is my biggest pet peeve is that phone number. How many times are we missing a number, or there's one number flipped over?
Or the best number to reach them at. And just because of the number that they call on, say you pick the phone up on a cold call, that might not be the best number to reach them at. So always confirm what's the best number to reach you at and get that documented in the tickler.
Document important things for somebody else if they're following up. Wow, this person lets the phone ring 10 times because they have to move across the room to get to the phone.
Right.
Let me get my hearing aid. Hold on, I gotta grab a pen.
I work. I might not be available till noon, or call me after 4. Those are all important things to get that response better.
So that the patient doesn't feel that, one, we're either hounding them too much, or that we didn't respond back to them, because there's still times I call people and it's just rings and rings. There's no voicemail, just rings and rings. Document that in there, left voicemail, returning patient's call. There's a lot of times I go to a phone message and the most important information is all the way at the bottom. And if you don't scan all the way down, why do you have to go all the way down? You should be having that. If you're documenting stuff into a chart, I'd way rather come and see a big chunk of patient has this is when it started, these are the side effects, this is what they've tried.
The more important stuff.
Yes,
at the
this
beginning.
doctor, there's a lot of times patients don't want to speak to other doctors, they don't want to speak to other technicians. If a patient states, I do not want to say this to another technician again, they've had a couple phone calls, and that needs to be documented in the chart at the beginning, not at the bottom, because there's too many times where we're running busy, and even though we're supposed to be reading everything, if it's up at the top,
it catches your attention.
If this is something for a doctor to address, put Dr. So-and-so, Dr. Kernan, do this. Dr. Ansari, do this. Get that doctor's attention by saying that. But you also don't want to make something that is urgent or non-urgent
Right.
into something that's like, woo, the doctor needs to call him now,
Might not be.
And it's just something that is like they just wanted to discuss their last review. Hi, Jessica.
One other thing we want to do is make sure we follow up if needed. Don't just make the phone call, and if you have to leave a message, leave it at that. They would much rather talk to you because who knows, maybe their voicemail is full, or they don't check their messages. It's much better just to, that you left the message, but follow up later to make sure that they got all the information that they need.
And part of that is reassuring the patient. You're giving them your name so that they know who they talk to. It's hard when we call somebody, it's like, well, who did you talk to? I don't know. Somebody, I just dialed the phone. We have 3 offices, busy practice. Put your name down there. I sign mine I always sign mine.
Yep.
Always. So using your name is key. Remaining calm, reassuring that patient that you're going to take care of this at this level, that you've signed on to take their medication.
And I've heard you do that, and I do that too. When they have a name and you assure them, you know what, if you need to call back, ask for me by name because I'll help you.
It's not uncommon for people to say, well, I can never get a person. They already have had to leave a message. You're calling them back, and then they're having to re-explain things. Sometimes you're the second or third person that they've talked to, whether it be a prior authorization or they're just trying to find out what's going on.
Test results.
Medication. Everything that you deal with that patient is a part of your practice, and you want that to be embodied in how you handle that patient. Never assume on a phone call.
Because we know what assuming does.
That's right. That's right. Never assume. You just don't assume that the patient is taking the medication that you think that they're taking.
Or what's instructed. That the last impression might be what the doctor told them to do, but it might not be what they're doing.
A lot of patients say, I never heard that, even though we have a scribe documenting everything that's documented. into what was said in that room, the patient doesn't always hear it.
Yeah.
Even if we gave them paperwork and it's all written down, a
Yeah.
lot of our patients don't see that paperwork. You can give it to them, and they are dilated a lot of the times when they leave. They've gone through a lot. They're trying to absorb all that information that the doctor is giving to them. So when you have follow-up phone calls from a visit, I always tell them, let me see what the doctor said. Let me review your chart so they understand that what I'm conveying to them
is what the doctor
wanted.
Yep.
And
very good.
You can always tell a patient, we will call you back.
Yep.
Have them confirm. Have the patient tell you what's the best number that they can be reached at and when.
Yep.
It's just like so important when you call and it's like, well, I'm at work.
Yep.
Or you call the work number and they don't answer because, well, I'm at work.
Yeah.
Just because they're at work,
doesn't mean, that's the best place to reach them.
And so,
so we hope that this helps you realize that we not only take care of the patients that walk physically into our office, but how important it is to take care of those ones that call us on the phone. And we have to take that very seriously and take good care of our patients that way too.
So the gold standard for messages, just as a quick rundown, you're taking somebody's verbal concerns and issues, whether it be a medication refill, talking to a doctor, them calling back just to confirm something, and you're documenting it. See this big word here? Documentation.
Because if you didn't document it, you didn't do it.
That's exactly right.
Yeah.
So it needs to go in the chart, and we thank you for talking at the View, but we do have our do's and our don'ts.
Yep.
Barb?
We never, ever, ever touch the cornea until all of your cataract measurements are done, which includes the A scan.
You never ever touch the cornea prior to doing the A scan unless you've got all your measurements done.
Yep.
You sit down to do an A scan, you're going to have to touch that eye. No touchy until the cornea has been measured.
Yep.
Once you touch it and you disturb that front surface of the eye, then you may change something that could become permanent in the eye.
Very, very important.
And so that's why we got two nevers that are the same, just spoken in a different way.
File it.
And thank you for watching The View.
Till next time.
Bye.